Good afternoon, everyone. Welcome to the June 26, 2024 WPS Jurisdiction J5 and J8 LCD Proposed Draft Open Meeting. My name is Denise Nachotsky. I am a WPS J5 and J8 Contractor Medical Director, and I'm going to be the moderator for this open meeting. At this time, before we start with the presentations, I will have a few logistics to go through, but I would first like to introduce my fellow CMDs, Drs. Claudia Campos, Dr. Juan Shaning, and Dr. Joelle Vlahakis as lead CMDs for their respective proposed drafts today. They will provide the summary of the pertinent data prior to the presentation and/or open comments. So if the three of you want to say hi, by all means, please do.
Good afternoon, everyone. Thank you, Dr. Nachotsky.
Good afternoon. I was going to go in alphabetical order, but Dr. Shaning is a gentleman, so I know he's waiting for me. I'm Joelle Vlahakis. Thank you for all your participation.
And not hearing any comments currently from Dr. Shaning. Let's hope he doesn't have computer issues. I'm just going to say from the start to all our attendees, please note that our organization has changed platforms from the WebEx to the Teams. So if there are any IT issues, I'm going to apologize up front. At this time, I'd also like to introduce Mr. Richard Staley. He is our Policy Administrative Assistant. Rich is responsible for all the behind-the-scenes coordination of these meetings, communication. He is the monitor of all the regulations and deadlines and successfully running these meetings. He truly is an invaluable member of our team, so thank you, Rich, for all your time, efforts, and skills. At this point, I'm going to start with just some of the logistics. And so what is the purpose of this open meeting? Okay, for all of you here, the open and any new ones coming and attending these open meetings, it really is an opportunity for interested parties to discuss the rationale, to review the evidence, and to provide feedback on proposed local coverage determinations, or LCDs. Our interested parties are generally those affected by the proposed LCD, including but not limited to physicians, providers, beneficiaries, caregivers, vendors, and manufacturers. We at WPS, we do invite members of the public and stakeholders to attend and provide verbal comments or statements on the proposed LCDs that we present today. Anyone that is attending the call can offer their comments, and prior approval to participate in your comments is not necessary unless you are a presenter. Please note up front that this meeting is recorded according to regulatory guidance. Personally, and behalf of my WPS colleagues all on the call, I truly appreciate all the attendees here, be it physicians, providers, beneficiaries, vendors, and manufacturers, and to all the presenters who took time out of their extremely busy medical practices and schedules to participate in this meeting. It should be stressed that it is the collaboration of all of you with the MAC that will lead to successful policy development that ensures and provides medical safety, medical necessity, and the appropriate medical standards of care to all of our beneficiaries, supported by regulatory guidance and current peer-reviewed medical literature. So today's logistics, I know Rich may have the screen up there. Here's a few ground rules. As I said already, number one, anyone can make comments on a policy being presented today. Please identify yourself before speaking for the recorded transcripts. If you are presented today with a documented presentation, Please inform those on the call of any conflicts of interest. You will be stopped after 10 minutes to allocate equal time for all other presenters, and Rich will provide a 2-minute remaining time notice for the presenters. There are 6 proposed draft LCDs and 9 presenters today with today's meeting. Regarding disclosure requirements per the 21st Century Cures Act, please note that the WPS GHA, we must provide, record, and publish recordings of open meetings held for the purpose of discussing draft LCDs. Interested parties can make presentations of information related to any of these draft policies. Your attendance as an interested party or as a presenter here at this meeting implies that you consent to the public disclosure of your opinion and agree that it may be used and will be clearly identified as your opinion within the proposed or final draft LCDs that are discussed. As far as written comments from today's meeting, please feel free to send in written comments. They will be due by the end date of the open comments period. There are 2, which I will discuss momentarily. There are 2 open comment periods, July 14th for 5 drafts, and one will be July 20th, which is for the cosmetic and reconstructive surgery. Please send your written comments to Medicare Policy Comments at WPSIC.com. When you send your comments, please include the topic of the LCD on the email subject line. We ask that you include any additional published scientific studies and/or literature to support additional coverage with your message. WPS will not send individual responses to the comments. We will make responses available in a comment and response document, also known as the Response to Comments article, that will be posted with the final LCD. So, with that logistics and the groundwork done, I'm going to start with the presentation of the draft LCDs. As I stated, there are 6 draft LCDs for this open meeting. Rich, if you could kindly put the agenda up today so people who are on the teams can see the LCDs. For attendees that are participating via phone or dial-in and without webinar access at this open meeting, I will state for audio communication the proposed drafts. As I stated, there are 2 open comment periods. The first open comment period will be from May 30th through July 14th, 2024, and it will be for the 5 draft LCDs, DL 39905, which is cataract surgery, number 2, DL 39907, which is for microinvasive glaucoma surgery, or MIGS, DL 39909 for botulinum toxin injections, number 4, DL 39911 for total joint arthroplasty, and finally DL 39913 for artificial intelligence enabled CT-based quantitative coronary topography. The second open comment period is from June 6th through July 20th, 2024, and that will be for draft DL 39051, which is the cosmetic and reconstructive surgery proposed LCD. Now for transparency, I'm sorry, is there a comment? Okay. For transparency, and per the CMS regulatory guidance through the Social Security Act, Section 1862, Section 1.5, and the updated IOM Program Integrity Manual, Chapter 13, post the Cures Act, all proposed drafts are and were appropriately posted to the WPS portal as well as the CMS MCD portal. Now, given today we have a very busy schedule, there is a significant number of presentations. So to try to accommodate everyone, what we're going to do for efficiency is we will begin with the proposed LCDs that have presenters given all their time and efforts in making their presentation. The LCDs will be presented in numerical order of the proposed drafts, and the presenter's order was based on the timeline of the requested date to present. Oral public comment will subsequently be taken after each proposed draft is summarized by the lead CMD for that policy and after any public presentations for that policy. As I stated, there are 3 proposed draft LCDs without requested presentations, and those will have only oral comments, and I'm going to leave those to after the presenters. After every presentation that we have, Rich or I will state that we will also take oral comments, and then you'll be able to unmute yourself to present oral comments after the presenters. Again, I've stated the written comments, and Rich will probably put this at the end as a slide. Any written comments, please send to the Medicare Policy Comments at WPSIC.com. So let's start with our presentations. We're going to first start with the draft DL 39907, that is microinvasive glaucoma surgery, or MIGS. Please note that this is a new LCD. It was MAC initiated. It is a collaborative multi-jurisdictional draft LCD. There was an evidentiary contractor advisor committee meeting in January 5th, 2023. Our lead CMD is Dr. Juan Shaning, and I'm going to let him now present a summary of this LCD.
Thank you so much, Dr. Nastelski. This is Dr. Shaning. I first want to say thank you for participating on this open meeting. I was having issues with my mute button when I was presented initially, so I just wanted to welcome everybody. So as Dr. Nastelski mentioned, this LCD is a collaborative LCD that had an evidentiary meeting that was hosted by Palmetto, CGS, NGS, Noridian, and WPS. The input obtained from the previous comments was taken into consideration in the development of the current proposed LCD, and the input of subject matter experts is referenced throughout this policy. This LCD allows one iStent Inject W or Hydrus, a trabecular aqueous stent device per eye as medically reasonable and necessary for treatment of adults with mild or moderate open angle glaucoma, and a cataract when the individual is currently being treated with an ocular hypotensive medication and the procedure is being performed in conjunction with cataract surgery. In addition, the iStent Infinite device and the same 45 subconjunctival space stent device are considered reasonable and necessary for glaucoma standalone procedures in whom previous medical or surgical treatment has failed. For covered indications, the number of stents allowed will be consistent with the stents contained within the device. The LCD considers one device per eye, reasonable and medically necessary when used per covered indications. This proposed LCD was open to comments on May 30, 2024, and will be open to comment until July 14, 2024. And now I would like to allow Dr. Andrew Powell to comment on this LCD on behalf of the American Ophthalmology Association, American Academy of Ophthalmology. Go ahead, Dr. Powell, please.
Thank you all very much, and my great appreciation that I'd like to extend to Dr. Shaning, Dr. Nachadsky, and all of the WPS Medical Directorship. My name is Dr. Andrew Powell. I'm a clinical assistant professor at the University of Iowa, and I have actually spoken on behalf of the Academy and myself last year in part of these conversations about this draft, LCD. I greatly appreciate the opportunity to speak with you all again, and I greatly appreciate, and I'd say the Academy and the American Glaucoma Society, we all greatly appreciate the collaborative cooperation and discussions that WPS and other MACs have allowed us to have regarding this. Are you all able to see my screen okay?
Yes.
Thank you very much. So last year, if you saw me chatting in open comment previously, I may have had more hair then, but that's the main personal update there on my webcam. I have no personal disclosures. I try to keep my nose pretty clean as an academic doc, especially when it comes to these sorts of things. And while I think the majority of our kind of conversations and more getting into the weeds and the details of things, we had more conceptually to talk about in prior meetings, this presentation is mostly just kind of fine-tuning, I'll put it that way. So among the indications of coverage that the current draft LCD covers, we wanted to point out the two here, and the first one we have no comments on, no recommendations or recommended changes. The second point about the supraconjunctival space, we do have a small editorial correction to make sure that the verbiage more appropriately states subconjunctival, which is more anatomically correct, and then just a little grammatical correction. The third point, which this one in the red down below, is not actually one of the currently stated indications of coverage, but it's added here mostly to clarify the next slide, which talks about, which reiterates the current limitations of coverage, the points listed there in the current draft. Point 3 is the point that the Academy of Ophthalmology and AGS would like to clarify a bit, that cataract surgery, also called phacoemulsification using modern cataract surgery techniques. Phacoemulsification is that modern technique for cataract surgery. We wanted to clarify and instead state in the indications of coverage essentially the same point, that cataract surgery can be performed with a single MIGS procedure. The points that we have...
I'm listening to a webinar.
I'm sorry? I'll proceed, sorry. The third point that we have sort of suggested some rephrasing of here is just to clarify exactly what would not be indicated for coverage, with a particular array of possible combinations being cataract surgery plus stent MIGS procedures, plus canaloplasty types of MIGS procedures, which also include goniotomy. It's just a recommendation for more specific verbiage to clarify exactly what it would not be being covered. And then the bullet point number 2 is just some non-important, just grammatical edits as well. The Academy would like me to give an update as to the current body of evidence that it does continue to grow regarding the evidence for combining multiple MIGS procedures together in surgery. This is a case series comparing the Hydrus stent with cataract surgery to the Hydrus stent plus canaloplasty in about 42 patients in one group and about 35 patients in the other. This is a study out of Hopkins. Many of my former colleagues there were using this. This is just a status update. We are all very much aware and in agreement with WPS that more evidence is needed to clarify all of this. But for the moment, we do not contest that coverage is reasonably indicated just for one of these MIGS procedures in combination with cataract surgery alone at this time. The other point we'd like to make elsewhere in the LCD are some definitions, and most of the definitions we have no recommendations for. For the definition regarding how refractory glaucoma is to be defined, the Academy and the American Glaucoma Society and the American Society of Cataract and Refractive Surgeons, these three collective subspecialty bodies do have a consensus statement established previously on the definition of refractory glaucoma and we think it might be advisable to aspire for alignment of definitions, particular verbiage at least. And this is thankfully a pretty short presentation because all the members here and us have already done a majority of the work in clarifying things for this LCD. Again, we greatly appreciate everybody's cooperation and collaboration and the kind respect and appreciation and attention for this truly debilitating disease that requires so much of understanding on patients and trust with patients. These points I can certainly read aloud, but I do want to use my time to mention a personal anecdote. My own father has glaucoma, has had that since I was a child, and he was treated very appropriately with traditional glaucoma surgery. And he doesn't see well. He suffered complications. This is unfortunately true very much of the time with glaucoma care. It's an invisible asymptomatic disease until it irreversibly is not. And every one of our treatments has risk to it. And the difficulty before MIGS came around was we have only had a giant hammer to hit all stages of severity with. If I wish my father could have had all of these options available to him with far less morbidity, potentially not having gone blind in one eye, as he did with the traditional, more risky surgeries. If these MIGS procedures had been available, I think he and many of our patients would have enjoyed much less blindness and morbidity. These procedures are intended to try to also address disparities of care, that many of those traditional surgeries are just disproportionately risky for patients who are already disproportionately at risk, particularly those of Black and Latin or Hispanic ancestry, which these populations very often have disproportionate burdens of disease and higher surgical risk. And the second point here is essentially my anecdote about my father and many of our patients, that it would be lovely to avoid the burden of risk with less risky options. And the third point, we certainly do understand that more evidence, especially now with the point in mind about combining different MIGS, as some folks are experimenting and looking at in experimentation, we do know that more evidence is required, but we do ask for your continued understanding and appreciation for just the research process. It takes time to develop these higher quality studies, and we greatly appreciate everybody's patience and understanding as we continue to seek that evidence. And that is the end of my slides. I greatly appreciate everybody's time again. Thank you so much. I'm happy to answer any questions.
Thank you, Dr. Powell. That was a phenomenal presentation. I know that we've met with you at other times. I'm always learning from you. Great presentation. Thank you so much for sharing your anecdote about your father. At this time, we will now take any oral comments regarding this LCD. Please make sure just to unmute yourself. That's number one. And number two, when you are done speaking, please place yourself back on mute, and that would be greatly appreciated. Okay.
And this is Rich, the administrative assistant. For those of you in attendance, you would have to check the raised hand icon or press *3 on your touch tone phones, and I will unmute you. And from what I can see, there are no further comments on this proposed LCD.
Thank you, Rich. So we're now going to go to the second LCD, proposed LCD, please forgive me, DL39909, botulinum toxin injections. This is a new LCD. It is MAC initiated. It is a collaborative, multi-jurisdictional proposed draft. There was an evidentiary CAC meeting October 19th, 2023. Our WPS lead CMD is Dr. Joelle Vlahakis, who will then give a summary, and then we will proceed on with our presenters. Thank you.
Thank you, Dr. Nachovsky. So This particular LCD or local coverage determination has been developed to create a policy consistent with current evidence for FDA-approved and off-label uses of botulinum toxins in our Medicare population. This is, as stated, a collaborative multi-MAC LCD, and it expands the number of covered diagnoses treated with botulinum toxin. This policy was written to be inclusive of the variety of disorders which avail themselves to botulinum toxin treatment. Care was also taken to adhere to treatment guidelines, including dosing type, the dose itself, and the frequency based upon the highest quality of evidence available at this time. Botulinum toxin dosing must be in accordance with the U.S. FDA approved labeling. For off-label botulinum toxin use without an FDA-approved dosing indication, the qualified healthcare professional must provide robust published clinical evidence to support the dosing use. The same is true for off-label use without an FDA-approved serotype indication. For new FDA-approved indications for the toxin serotype or dosing recommendations after the effective date of this policy, the qualified health professional must provide the updated published FDA prescribing information to support the use of the toxin serotype or dose. Botulinum toxin administration must not be given more frequently than every 12 weeks, regardless of diagnosis, unless specifically addressed in the policy. The use of Botox for all cosmetic procedures is not a covered benefit under Medicare. When Botox is used for an approved diagnosis, but the botulinum is also being used with cosmetic intent, the entire claim for the botulinum is not considered reasonable and necessary. Specific indications and limitations of coverage are provided in each section for each diagnosis, including esophageal achalasia, anal fissure, blepharospasm, orofacial dystonia, cervical dystonia, chronic migraine, migraine headache prophylaxis, focal hand dystonia, hemifacial spasm, facial dystonia, hyperhidrosis, laryngeal dysphonia, neurogenic bladder, overactive bladder, urinary incontinence, sialorrhea, upper and lower spasticity, that should be upper and lower limb spasticity, and strabismus.
Thank you so much, Dr. Vlahakis, for that very thorough presentation summary. At this time, we do have 3 presenters for this LCD. And so I'm going to start with Dr. Eric Busby. Please correct me if I said your name incorrectly. And Rich is getting ready to get his slide presentation.
Okay, can you hear me? All right, hello everyone. My name is Eric Busby, and on behalf of AbbVie, the patients that we serve as the manufacturer of Botox, which you will also hear me call onabotulinum toxin A or Onabot throughout this presentation, I want to thank the committee members here for the opportunity to speak to this draft policy on botulinum toxins. Next slide, please. I will first go through my disclosure. I am a full-time employee of AbbVie. I'm an associate scientific director, medical payer strategy, and I'm also a shareholder. Next slide, please. I will be covering a lot of information in this presentation, and I will do my best to bucket many of our comments. Just note that AbbVie will be submitting detailed written comments, including PDFs per process. So throughout this presentation, I will be providing key takeaways per slide. Next slide, please. So to orient you to these slides, anywhere that we have highlighted something from the draft policy, we have respectfully asked for revisions, given information, other evidence that is available. So the light blue box that you will see on the following slides gives you an idea of what we are requesting. So here's slides 4 through 8. We'll cover some key areas of focus on education of coverage, starting with chronic migraine. So for chronic migraine, we are respectfully requesting the removal, requiring a 2-month trial of pharmacological therapies before the use of onabotulinum toxin A. This request is in alignment with the most recent AHS guidelines update. Also, some of the products that are listed in the proposed policy are not indicated by the FDA for migraine. For statement number 8, the language here is unclear as written. And so we do seek to understand likely what the language is suggesting to occur in combination with, in relation to combination therapy. And so we are requesting that the exact verbiage be revised and considered to ensure that patients that are suffering from chronic migraine receives the appropriate care. Next slide, please. So with regards to spasticity, the items that you see highlighted above from the draft policy to remove moderate to severe, this is misaligned to current guidelines as well as the FDA approved indication for both adult and pediatric spasticity patients. Next slide, please. For cervical dystonia, we are requesting that the policy be revised given the following: that the AAN guidelines do not state routine assessments utilizing objective measurements. Anabot A is approved broadly to treat cervical dystonia associated with neck pain. Next slide, please. For neurogenic detrusor overactivity, we are requesting that the moderate to severe statement for NDO is removed from current policy, as it is not aligned to the FDA approved label, nor is that a statement suggested in the clinical guidance in the new AUA SUFU guidelines for NDO. Next slide, please. So for OAB, we are requesting the following: that moderate to severe and objective assessments are removed. And number 2, to eliminate the need for conservative and pharmacological management before onabotulinum toxin therapy. So in the most recent updated OAB guidelines, it states that clinicians may offer patients minimally invasive therapies such as Anabot A without requiring trials of behavioral, non-invasive, or pharmacological management. And furthermore, the guidelines acknowledge a potential association between anticholinergics and the risk of dementia. Next slide, please. So here we are respectfully requesting for revision to the definition of spasticity. There was a recent update to the definition, and so this information can be found in the 2024 AAP M&R Consensus Guidance on Spasticity Assessment and Management. Next slide, please. So for muscle selection in cervical dystonia, we are requesting that the policy revises its statement to expand to any of the approved muscles for Anabot in cervical dystonia, noting that the highlighted muscles here are only some of the approved muscles for cervical dystonia. Next slide, please. For spasticity, we have noted that the maximum cumulative dose of 360 units is a historical dose, and so the latest cumulative dose of Anabot A in spasticity is 400 units that is related to adult lower limb spasticity that was approved by the FDA in 2016, as well as additional safety information. We will also be providing the committee with studies that show that doses of 600 units of onabotulinum toxin A is safe and efficacious in patients with adult lower limb spasticity. Next slide, please. So furthermore, for spasticity, we've noted that some of the other approved botulinum toxin had pediatric dosing mentioned. And so AbbVie would like to respectfully request that Anabot A is also approved for pediatric spasticity, age 2 years or older, and that the dosing information for pediatric upper and lower limb spasticity are included into the policy. Next slide, please. So for this slide and the next slide, this slide is on NDO, the next slide is OAB. We will be providing the committee additional details, including phase 2 and phase 3 data that supports higher doses for those patients who are not achieving efficacy from the typical on-label dose. So please go 2 slides. Okay, so here for blepharospasm, We request that the wording in the policy reflect what's in the FDA approved label to state that onabotulinum A to state per site instead of per eye. Next slide, please. So here, there's a limitation in the use of guidance technology. So we are respectfully requesting that guidance technology such as ultrasound is included, and we will be submitting additional data on that. Next slide, please. And so lastly, there have been many ICD-10 codes from the prior policy that has been removed or admitted for reasons unknown to this draft policy. So we will be providing you a comprehensive list of these codes with supporting literature, and we are requesting that the addition of these codes are included into the final policy. Next slide. So just want to thank all of you for my time to comment today on this policy. Thank you.
Thank you so very much, Dr. Busby. Your comments and slides are greatly appreciated, and they will be shared with the collaborative work groups in regards to this, and we appreciate all the updated material that you have provided. Our second presenter is Dr. Kahana, who will be presenting her presentation, and she is from the American Academy of Ophthalmology. So thank you very much.
Thank you, Dr. Nachotsky and Dr. Vlahakis. My name is Alon Kahana. I am a professor and vice chair in the Department of Ophthalmology at the Oakland University William Beaumont School of Medicine. I have never presented to the WPS or AMAC before, so this is my first time. But I really appreciate the opportunity that you've given me. And I'm speaking on behalf of the American Academy of Ophthalmology, the American Society of Ophthalmic Plastic and Reconstructive Surgery, and the North American Neuro-Ophthalmology Society. I do not have, next slide. I do not have any relevant disclosures. I do have research grants that are not relevant to this. I have done some consulting that is not related in any way to either this drug or the companies that market it. I do have a PhD in molecular genetics, and for many years ran a research lab on the basic biology of periocular muscles, including their development and dysfunction. And in this context, I consider myself to have significant expertise in speaking about periocular muscle dystonia. Next slide, please. Blepharospasm is the particular topic of my presentation. It is the abnormal involuntary contraction of the eyelid and periocular muscles, particularly the orbicularis oculi muscle. And once starts, it is a lifelong condition. It is an uncommon condition, referred to as benign essential blepharospasm when it is not associated with another condition. And it can typically begin as a relatively mild contraction, a true dystonia though, and can progress to become very forceful, frequent, and extremely debilitating. It does not, because of the imbalance between the eyelid opening muscles and the eyelid closing muscles that is caused by this dystonia, the eyelids cannot open even though the eyelid opening muscle themselves are actually functional. They just cannot overcome the dystonic contraction of the eyelid closure muscle. Botulinum toxin weakens the dystonic, dysfunctional eyelid closing muscle, specifically the orbicularis oculi, but also the brow depressor muscles. And by doing that, they rebalance the eyelid opening and closing functions of the muscles so that people who have this condition can open their eyelid and see. There are clinical guidelines that exist for dosing these injections. And this treatment has been used for decades, at least 4 decades now. So we have a tremendous amount of expertise in using this treatment option for patients, and it is the first line treatment for a relatively uncommon but extremely debilitating, even blinding condition. And imagine that you have a normal eye, but you cannot actually see because you cannot open your eyelids. Next slide, please. Now, with regard to the LCD coverage criteria, as you can see, the criteria for benign essential blepharospasm mirrors the dosing guidance language within the FDA label, which was approved in 1989. The specific portion of the LCD cites the package insert, so we know that the FDA approved it in this particular way. You'll also notice that there are language changes that are being proposed here in the LCD for 2024. Our greatest concern is the LCD's limitations section. And I'm going to quote, "Little benefit from injecting more than 5 units per site," which is the old guidance, the old label from 1989, has been changed to 5 units per affected eye. And my reading of it is that this is just actually a simple error, that the original guideline was miscopied, because 5 units per affected eye is going to be utterly ineffectual in treating these patients. It should be 5 units per site. Next slide, please. So we do need the clarification about that. Now, there are various reasons to be concerned with this application of the FDA label. Because FDA package inserts are not intended to be used as absolute treatment guidelines. The FDA label still provides treating physicians with broad discretion in taking care of individual patients. And there needs to be the ability of the treating physician to adjust the exact location of the injection and the exact dosing of the treatment to the individual patient. This is not a cookie cutter disease. And even though we call, let's say, the orbicularis oculi muscle has one name, but we know that there are different parts of the orbicularis oculi muscle, and they participate in the dystonic closure of the eyelids in different ways. The pretarsal, the preseptal, the orbital, the lower lid, the upper lid, they can be contracted differentially in individual patients. And we need to have, as treating physicians, the ability to treat the individual, not some kind of a copy-paste patient that doesn't really exist. So using the proposed criteria as a coverage guideline would arbitrarily limit and deny care, and preventing escalation of treatment as the disease progresses, leading to preventable vision loss. Now, we do appreciate the LCD's acknowledgement that this is an off-label use technically, but because this is the standard of care and has been for decades, requiring the submission of multiple studies to back our current treatment protocol is very burdensome on Medicare providers and is probably not realistic in the context of taking care of these patients. Next slide, please. What we would like to see is elimination of overly restrictive limitations on dosing, sites, amounts, because not doing so would result in delays and denials of medically necessary care. And even though this is an uncommon condition, but when it's not rare, it's uncommon. When it presents, patients oftentimes are at their wits' end. It takes a while to figure out what's going on because these patients start with what looks like a droopy eyelid, but it's variable. Sometimes it's there, sometimes it's not. They get worked up for other conditions such as myasthenia gravis.
2 minutes remaining.
Okay. And so I have examples of real patients. For example, a 68-year-old man, these are patients of mine, in Michigan, on the west side of Michigan, who looked forward after retiring from an automotive job to playing golf. And he developed this disease, could not open his eyes, needed to have a driver bring him all the way to me for treatment, and has done very well with botulinum toxin treatment. But as the 3-month date approaches, he is already losing the effect of the Botox treatment. And so for the last 3-4 weeks before his next treatment, he is really, really debilitated again and needs somebody to drive him. Otherwise, he's fully functional. 62-year-old middle school teacher in Michigan who's having trouble driving to work and maintaining the attention and respect of her students when she has these episodes of blepharospasms. And she's doing very well with Botox injections. And I have a 45-year-old mother of 4 who's struggling with driving them to their various activities because her eyelids close on her when she's not getting the Botox treatment. And again, doing very well with Botox. Next slide. And so our recommendations, next slide, is that the new policy should support the effective standard of care that we've been using for the past 4+ decades. We're talking 40 to 50 years, where we allow treating physicians to treat multiple sites where the dystonia actually occurs, using the dose between 2.5 and 5 units per site that provides effective treatment. And with that, I will again thank you very, very much for your attention and for giving us the opportunity to present on this really important topic.
Dr. Kahana, thank you so very much for this presentation. It is actually very enjoyable to listen to so many of our physicians in practice here, as with the other presenters that we had. The pathophysiology that you gave of blepharospasm, I feel like I'm in a CME and I want to claim CME credits for your teaching. Very much appreciated. In remarks to, the limitations of the 5 units per site versus I, that has been recognized and will be corrected. I think that was an oversight, but we appreciate everyone's attentiveness when they read the policy, because you really are there on the forefront for our patients. And again, thank you for the scenarios of your patients. It really hits home what you're trying to do for the people in the community. So very, very much appreciated. We have one more presenter for this LCD, and it is Dr. Mann. Thank you very much for putting that up, Rich. And we're going to let her present. Thank you.
Okay. Are you able to hear me?
Yes.
Okay, perfect. Thank you for confirming that. Thank you for the opportunity to present here to the open committee. Introducing myself, I'm Amandeep Mann. I'm the medical director for Ipsen Biopharmaceuticals. That is a manufacturer for Dysport, or abobotulinum neurotoxin A. I'll be referring to Dysport as Abobont A or Abo throughout the presentation. Next slide, please. Just to start off with disclosures, I am a full-time employee of Ipsen and hold shares of Ipsen stock. Next slide. I did want to start with a disclaimer that this presentation is in response to MAC request for feedback on the updated MAC draft LCD policy consistent with the FDA approved, as well as the off-label use of Bont A's for the Medicare population. At this point, I do want to recognize that I do want to recognize the group, so really thank WPS and CMS members for their efforts for updating this very comprehensive LCD policy. And for this presentation, I'll just be walking through some of the key sections of the draft policy that we hope can be updated to improve the access for Medicare population. And in select sections, I'll be requesting the expansion of the coverage for Dysport or abobotulinum toxin A. Next slide. Before I get into the indications, I do want to indicate that Ipsen will be submitting a detailed response letter that will include all the relevant supporting references, in addition to the areas that we are requesting for a change within the policy for the group to consider for the final LCD policy to be submitted. Just to start off with the approved indications, so the FDA has approved the use of ABO in the treatment of cervical dystonia in adults, and this was approved in 2009 in the US, and the treatment of spasticity in patients 2 years of age or older. I do recommend that everyone refers to the ABO prescribing information for complete details in the box warning for distance spread of toxin effects, contraindications, warnings, precautions, as well as adverse reactions. Next slide. This is just a nice sort of summary and a historical perspective on Ipsen as well as Dysport or abobotulinum neurotoxin A. It has been marketed for over 30 years with multiple more than 5 million patient treatment years experience and over 1,300 peer-reviewed publications. And that's across multiple indications that are not limited to cervical dystonia and spasticity. So globally, we do have indications beyond cervical dystonia and spasticity. Next slide. So we'll go through 6 key areas that we'll be able to present on within this time frame of 10 minutes, really requesting the changes within the policy. The first request is to update the indications of coverage to be more inclusive of the CD and spasticity patient population that can be treated with toxins, so BoNT/A, and to avoid restricting the access to patients that are either suffering from moderate or severe spasticity or cervical dystonia symptoms. So the support there is that the FDA-approved label for ABO is not limited by disease severity, so it is a very broad indication. The AAN guidelines do not recommend the use of toxins as a treatment within CD or adult spasticity based on the severity of the disease. It is recommended, at least ABO is recommended as the level A recommendation for the treatment for cervical dystonia and spasticity. In addition, the AAPM&R consensus guidance, which was just recently published in 2024, does not restrict or categorize the use of BoNT/A recommendations for the treatment by severity of spasticity. Next slide, please. The second request is to reinstate our on-label diagnosis codes that were omitted from the draft LCD policy. So they were originally in the policy and have now been removed. And this includes cerebral palsy, all paralysis or paraplegic classifications, contractures, as well as muscle spasms. ABO has an established safety profile and proven efficacy in phase 3 registrational trials for upper limb and lower limb spasticity, which has led to our broad indication for the approval within the US by the FDA for use in spasticity and is not associated with paralysis classification or specific symptomology. In addition, we do have phase 4 studies that reflect the real-world uses of ABO in varying populations of limb paralysis. Furthermore, our pediatric spasticity study, our registrational trial that showed the efficacy and safety of ABO in upper and lower limb spasticity, was evaluated in cerebral palsy patients. So it really supports the re-inclusion of CP and all paralysis codes within the use of Dysport. Of note, the types of paralysis and spasticity, adult or pediatric patients, can be classified as diplegia, hemiplegia, paraplegia, as well as quadriplegia. So according to the area of the body that is affected post the trauma or post the injury. Next slide, please. The third request is to update the CPT code title, spastic hemiplegia, to spasticity, which was what the original title was in Group 14 for ABO-BONT A. And this is, the draft LCD title is highly limiting and may unduly restrict treatment of other types of spasticity in the Medicare population. So really, the same data that supports the previous request for request number 2, it's that the data supports the general, the use of BONT A's or ABO-BONT A in spasticity patients and is not restrictive of the type of spasticity or the severity of spasticity. In addition, we do have our phase 4 studies as well as our pediatric studies that do support the use of toxins across patients beyond spastic hemiplegia. Next slide, please. So the fourth request is really focused on including our on-label muscles for cervical dystonia, which are not all included. So there are 4 muscles that are missing from the policy that are within our FDA approved label. In addition, I wanted to highlight and bring attention to the on-label dosing recommendations for abobotulinum neurotoxin A for pediatric spasticity and adult spasticity that are incomplete in the policy and should include ALL dosing. So those are the red box dosing guidance that we have within the FDA that is missing from the policy to be included. So the max dose of 1,500 units for ALL, and then you have the pediatric upper limb spasticity dosing with ABO with 8 units to 16 units per kg per limb as a starting dose, and then the max dose of 640 units or 16 units per kg. Next slide, please. The 6th request is focused on the inclusion of the CPT code focused on ultrasound image guidance in the treatment of spasticity and cervical dystonia. When injecting ABO, the use of guidance technique is recommended in our FDA-approved label and prescribing information. Additionally, there is published data that supports the use of guidance techniques to mitigate—
2 minutes remaining.
Almost done. Thank you. So additional literature does support the use of guidance techniques to mitigate adverse events by helping visualize the target injection sites. There's also data that supports that's supported by our recent publication or our recent study named ABOLISH. That's a phase 4 ALL study looking at the treatment of ABO in adult lower limb spasticity patients. And we showed that actually patients where ultrasound guidance was used, we had better patient outcomes with the use of ABO versus those patients that did not get ultrasound guidance with their treatment. And next slide, please. So the 6th request is really reinstatement of ICD codes, ICD-10 codes for ABO that were originally included in the policy for Dysport, and I'm going to specifically call out other dystonias, but also we'll be providing support for consideration of additional codes for ABO in terms of data that is supportive of use of that provides evidence for the use of ABO within other indications. So just as a historical background, one of the first indications approved for ABO actually in Europe was blepharospasm and hemifacial spasm in 1990s. And I would really like to bring awareness to this existing publication or published data on ABO in other conditions that fit under this category of other dystonias. So blepharospasm and hemifacial spasms, but it's not limited to these 2 indications. In addition, we'll be providing support for ABO use in other conditions such as neurogenic detrusor overactivity, hyperhidrosis, as well as migraine, which are also indications that are approved outside the US for ABO. I do refer you to look at the Ipsen comprehensive written response that will be provided in July, so to be submitted with supportive references with additional details. I do want to thank the committee here for giving me the opportunity to speak on behalf of Ipsen, and we look forward to submitting our written response, and along with the supportive ABO data and the PI for your review. And I hope you consider our suggestions in relation to ABO coverage in the final policy so that Medicare patients can have access to treatment options to manage their chronic and debilitating conditions like spasticity and cervical dystonia and other indications as well. I thank you for your time.
Thank you very much, Dr. Mon, for that. At this time, I will open up for comments from everyone. I do want people to know the timeline here. We are technically have 58 minutes left to this meeting, and there are several other policies and presenters. So, Rich, I will leave it to your discretion when we may have to limit the oral comments to proceed with the next presentations. Thank you.
All right, if you do have any comments to make on this, please raise your hand at this time. We have John Barretta. I have sent a request to unmute you.
John Barretta. I am a physiatrist, a PM&R physician who treats people with spasticity, both upper and lower limb spasticity. I wanted to voice my concerns about the change to accepted codes, diagnosis codes for people with spasticity. I am concerned that the proposed changes to the acceptable codes will leave many people who have been previously treated with botulinum toxins for spasticity unable to obtain coverage. Specifically, populations that appear to have be potentially losing coverage include those with spinal cord injuries, both paraplegic and quadriplegic spinal cord injuries, as well as those with cerebral palsy. The inclusion of a spastic hemiparesis code is helpful for those with stroke and brain injury, but it is limiting to those with other patterns of spasticity. Thank you.
Thank you for your comments. Again, any written comments, please send to the Medicare Policy Comments at WPSIC.com and include the topic of the LCD with your comments, as well as published or scientific studies or literature to support your comments.
Thank you. And any other comments before we move on to the next presentation? Raise hand or *3 on your touch tone phone. And I see no further comments. Please proceed, Dr. Nachatsky, with the next.
Thank you so very much. The next LCD or proposed LCD is DL39913, Artificial Intelligence or AI enabled CT-based quantitative coronary topography, also known as AI-QCT, coronary plaque analysis or AI-CPA. This is a new LCD per stakeholder request. It is a collaborative multi-jurisdictional proposed draft LCD. There was an evidentiary CAC meeting on May 25th, 2023, and I am the lead CMD regarding this policy. This policy was developed based for coverage for quantitative coronary plaque analysis using AI-enabled CT-based quantitative coronary topography and AI-CPA. The coverage indications, limitations, or medical necessity, excuse me, include that this policy is considered reasonable and medically necessary with this diagnostic tool when the patient is eligible for CCTA. And CCTA for people to know is coronary computer tomography and angiography. So the patient must be eligible for CCTA, and the patient presents with acute chest pain and no known CAD, and is classified as either one or both an intermediate risk patient based upon the 2021 societal guidelines for the evaluation and diagnosis of chest pain, as well as alternatively, are they a CAD RADS2 and CAD RADS3 category? And that is defined as by the CAD RADS 2.0 version 2022 coronary artery disease reporting and data system. an expert consensus document by the Society of Cardiovascular Topography, the ACC, the American College of Radiology, and the North American Society of Cardiovascular Imaging. Limitations for using AI, QCT/AI CPA. It's not considered reasonable or necessary in the following clinical circumstances. The test is never covered for screening, that is, in the absence of signs, symptoms, or disease. You have to have no contraindications to having the beginning CCTA. It cannot be done in conjunction with an invasive coronary catheterization. It is not to be used with abnormal CCTA results of CAD-RAD0 or no known plaque disease, nor is it to be used with a high-grade stenosis greater than 70% or a CAD-RADS 4 and 5 category. You cannot have a recent MI within the last 30 days. You cannot have unstable coronary symptoms, and it is not used for surveillance. So based upon this policy, we do have 5 presenters. I'm going to start with Dr. James Min, who is speaking on behalf of the Cleerly Incorporation.
Great. Thank you, Dr. Chodsky and the panel for the opportunity to speak in this open meeting today. Can you hear me okay? Perfect. Just by way of introduction, my name is James Min, and I'm a clinical cardiologist. I focused my career on coronary heart disease, large-scale clinical trials, advanced imaging in an effort to try to improve our understanding of coronary artery disease, the cause of heart attacks, which tragically remains the #1 cause of death in this country. Previously, I served as a professor of medicine and radiology at the Weill Cornell Medical College, the director of the Dalio Institute of Cardiovascular Imaging at the New York Presbyterian Hospital, and I was the founder of a clinical program called Heart Health that we founded in 2013, which was a precision heart care clinical program that served as our foundational experience for the AI QCT technology in discussion today that allows for advanced atherosclerotic plaque analysis. I think for full disclosure, I currently serve as the founder, CEO, and employee of Cleerly, which offers the AI QCT technology that I found to be so valuable in my clinical practice, having taken care of thousands of patients. First off, I'd just like to thank the medical directors of WPS, as well as the other MACs, for their thoughtfulness for this proposed coverage determination of AI QCT, which will invariably allow for the performance of advanced plaque analysis from non-invasive CT in select individuals. And we're looking forward to the opportunity to witness the application of this technology on favorably affecting the lives of patients with coronary disease, a task that can't be done by routine CT evaluation today. Our only encouragement to you would be to allow for the performance of AI QCT into 2 additional subsets of symptomatic patients who undergo CT, which we believe to have been unintentionally omitted from the current proposed coverage determination based upon the proven clinical evidence and the professional societal guidelines. Those 2 patient populations are those with stable chest pain, as well as those who meet the criteria of CAD-RADS1. I'll now try to provide for you the rationale for these 2 requests. If you can advance the slide. This slide shows that in the last 50 years in cardiology, there has been only 1 non-invasive coronary artery disease imaging test that has been ever demonstrated within the context of a well-performed randomized controlled trial to favorably influence patient outcomes in symptomatic patients without known but with suspected coronary disease, and that test is coronary CT angiography. The non-invasive test, as you can see on the bottom left, is rapid, it's safe, and based upon its benefit to improving patient lives, has now achieved the sole level 1A indication in the American Heart Association guidelines for the evaluation of both patients with stable as well as acute chest pain who present with coronary disease. Germane to the discussion today, on the 2 figures on the right, the first one you see is the invasive angiogram. The yellow lines bookmark an area of the artery that shows no blockage, significant blockage. On the right, you see the non-invasive CT bookmark that also shows no significant blockage, but the yellow highlighted area demonstrates very, very, very severe atherosclerotic plaque that is missed by conventional testing. This lesion is often referred to as a widowmaker lesion for good reason, and it is currently not easy to identify using conventional measures today. If you go to the next slide, this one randomized control trial that demonstrated the utility of CCTA imaging to improve patient outcomes was called the Scott-Hart trial. On the left, you can see that in patients undergoing standard of care versus CCTA, the CCTA group experienced a more than 40% reduction in heart attacks compared to the standard of care. When you look on the right, upon deeper examination of the reasons that drove the improved outcomes in patients undergoing CCTA, you can see that as compared to the standard of care, there were no differences between the groups for rates of invasive angiography, or CAF, rates of stenting, or PCI, rates of bypass surgery, or CABG. Indeed, the only difference in patients who underwent CT versus the historical methods of evaluation was a very significant increased utilization of life-saving preventive medical therapy. If you go to the next slide. Beyond the Scott-Hart study, the totality of clinical evidence in the last 20 years has demonstrated that at least 4 very important, actionable, patient-centric findings can be derived from advanced plaque analysis. The first is risk, right? And so plaque, and particularly a phenotype called low attenuation plaque, has been demonstrated to be the Sorry about that. Has been demonstrated as the strongest predictor of future heart attacks. This was found out in not only the Scott-Hart trial, but also in trials performed by our investigative group, the PROMISE trial in more than 10,000 patients, and the ICONIC study in more than 25,000 patients. Further, the field has demonstrated that not all plaques are the same, and that the phenotypic appearance of a plaque will strongly dictate its behavior and the risk to the patient, namely that non-calcified plaques are the higher risk plaques, and calcified plaques tend to be stable and even associated with lower risk of heart attacks. How can we utilize that in clinical care? Well, these findings allow us to use to guide medical therapy in a personalized and very effective manner, as we've been demonstrated to see that like favorable lifestyle interventions and medical therapy, they do less to regress plaque or make it go away, but more to transform plaque from this non-calcified into this calcified phenotype. In symptomatic patients who present with suspected coronary disease, this advanced plaque analysis would offer us a very unique opportunity to identify patients with residual risk, those who would benefit from more intensive lifestyle changes and medical therapy. Advanced plaque analysis can also help us promote precision heart care for invasive procedures, i.e. getting the right patients to the cath lab whose symptoms are due to coronary artery disease, and effectively avoiding unnecessary invasive procedures in patients who can be treated more conservatively with just medical therapy. Evidence has shown that the advanced plaque analysis allows us to pinpoint these patients who will benefit in a manner that is effective, independent, and incremental to prior coronary disease measures. If you go to the next slide. Due to this wealth of clinical evidence, the most recent American Heart Association and American College of Cardiology chest pain guidelines made several recommendations for the first time that encourage the use of advanced plaque analysis in patients with acute chest pain, as well as in patients with stable chest pain. I'd point you to the 4th bullet. That would be those patients in stable chest pain in which the guidelines highlight that these patients with non-obstructive coronary artery disease would significantly benefit from plaque analysis to guide therapeutic decision-making. And notably, in the AHA guidelines, the definition of non-obstructive is inclusive of those with a maximum 1 to 24% stenosis, for which that group experiences more than 40% of the heart attacks. That 1 to 24% stenosis is considered a CAD-RADS1 category. And if we go to the next slide, you can see that the American College of Radiology has recommended advanced plaque analysis for patients with both acute and stable chest pain, and also recommended it for patients with CAD-RADS1, which is defined by the 1 to 24% stenosis. What you can see in the blue shaded area is that in contradistinction to the AHA guidelines, the ACR CAD-RADS criteria also recommended plaque analysis for those with higher than 70% narrowings. Now, for this difference, we personally do not believe that advanced plaque analysis will offer that much. We think that those patients are already considered very sick and that they will be offered both maximal medical and invasive therapies, but we just point out that that is what ACR recommended. If you go to the last slide
2 minutes
here,
remaining.
Thank you. I would just say that in summary here, the evaluation of atherosclerosis, the plaque, is now widely considered the standard of care. by the American Heart Association, American College of Cardiology, and the American College of Radiology, but it cannot be performed manually. In our research studies, these analyses took up to 10 hours per patient, and the accuracy was not what could be done with powerful computational tools that would allow for routine and generalizable assessment of our patients. We again express our appreciation to the medical directors, as this is quite a fast-moving field of ever-increasing clinical evidence, and your proposed positive coverage determination will allow clinical practitioners for the first time to emphasize atherosclerosis as the primary treatment target. This is important because if you think about it, atherosclerosis is heart disease, while our other measures to date, such as blockages or abnormal stress tests, simply represent the downstream sequela of atherosclerosis rather than the disease itself. We would only respectfully request that WPS allow patients with stable chest pain, who represent the preponderance of patients enrolled in prior clinical trials, and those with 1 to 24% stenosis, who represent more than 40% of the patients who will suffer future heart attacks, be included in this coverage policy. In doing so, I think this very thoughtful coverage eligibility will enable many patients to be properly and comprehensively evaluated in a manner in keeping with the prior landmark clinical trials, as well as the professional societal guidelines. Thank you very much.
Thank you so much, Dr. Min. In view of the time that's going on, I'm just going to proceed next to our next presenter, and that is Dr. Martin, who is representing Mercy One Iowa Heart Center. Thank you.
Dr. Martin, are you on mute?
Able to, okay, there you go. Can you hear me now?
Yes,
okay,
we can hear
very
you
good.
now.
Thank you.
Please
okay.
proceed.
So yeah, I am Dr. Enrique Martin. I'm a cardiologist at Mercy One Iowa Heart Center, where I also serve as a medical director for advanced cardiovascular imaging, preventive cardiology, cardiometabolic clinic, and sports cardiology. So next slide, please. Next slide, please. So thank you for allowing me to speak about and comment on the proposed LCD for AIQ-CT. As you know, there are so much advancements in the use of AI in medicine, especially in the imaging field over the last few years. So thank you for creating an LCD regarding this. Next slide. Our evaluation of patients with chest pain and presumed coronary artery disease have evolved significantly over the last few decades. Now more than ever, with rising healthcare costs, it is imperative that we ensure utilization of cost-effective evaluation strategy with high sensitivity to ensure delivery of more efficacious, individualized, and personalized care to our patient population. As you all know, in 2017, the National Institute for Health and Care Excellence in the UK updated their guidelines and recommend cardiac CT as a first-line test for evaluation of stable chest pain patients. Here in North America, the publication of the 2021 Multi-Society Guideline for Evaluation and Diagnosis of Chest Pain was welcomed with much excitement and appreciation by the cardiology community, as well as by other societies such as those in emergency medicine and primary care. The following year in 2022, another multi-society guideline from the cardiovascular and radiology community was published on CADRADS 2.0 with a goal to improve reporting of coronary CTA to include not only severity of stenosis, but also plaque burden and lesion-specific ischemia. For this reason, I, along with my colleagues in the cardiovascular field, are very much supportive and appreciative of the creation of proposed LCD for AIQ-CT. AIQ-CT has been proven favorable in prevention arena for risk stratification of patients to guide aggressiveness of treatment that is tailored based on atherosclerotic burden. Obviously, we don't want patients taking medications that they don't need, but we do want patients to take more medications for those who appropriately needs it. This will in turn revolutionize our patient management strategy, which leads to a decreased healthcare costs and improved population health. As seen in the images provided, we are now able to focus on the presence of plaque in addition to stenosis. Remember that more than 50% of patients who present with myocardial infarction have stenosis that are less than 70%. Next slide, please. I do have some suggested changes to proposed LCD that I believe are very important to consider and will be a tremendous benefit to our patients. Next slide, please. And this is actually similar to what Dr. Min has just mentioned. It was mentioned earlier what the current proposed language are, but what I do recommend is to again add the stable chest pain and CADRADS1, which I will be explaining why in the next couple of slides. Thank you. Next slide, please. Limiting use of this technology to acute chest pain only limits patient access and in fact alienates the majority of our patients who presents mostly in the outpatient clinics. In fact, if we truly limit this technology to acute chest pain only, this will only encourage patients to present in the emergency room setting, which is already overburdened and quite often bursting in the seams due to the patient load and staffing issues. If we are to look at the SCART Heart study that Dr. Min has mentioned earlier, which is one of the largest studies on chest pain patients, all patients had stable chest pain, not acute chest pain, stable chest pain. And in this clinical trial, they reported a 41% reduction in fatal and non-fatal myocardial infarction using a coronary CTA strategy. More importantly, current ACC/AHA chest pain guidelines recommend reporting plaque burden in patients with stable chest pain, which is given a Class 2A recommendation that was mentioned earlier by Dr. Min. Next slide, please. To substantiate my second request for adding CADRADS1 to the current LCD language, let us revisit the Glagos phenomenon of vascular remodeling, which states that the arteries remodel to maintain constant flow despite increases in atherosclerotic lesion mass. Therefore, focusing on stenosis alone will ignore a good amount of our patient population who are at risk for major adverse cardiovascular events due to their atherosclerotic plaque burden. Remember that for us in the prevention world, we do use plaque burden to guide how aggressive we are in our patient management. This, we believe, is the holy grail in improving population health. I was looking at LinkedIn one day and I saw one of the preventive cardiologists post something that really strikes me very well. He said, prevent, not stent. And that really is what we should be doing. We already know that the previous things that we've done before, but stenting alone will not improve population health. We need to do better in prevention, and looking at plaque would lead us there. As such, current ACC/AHA chest pain guidelines recommend also reporting plaque burden in patients with non-obstructive coronary artery disease, which includes CADRADS category 1. This is extremely important to consider because over 40% of major adverse cardiovascular events occur in patients with less than 25% stenosis. Therefore, the population that's historically, and also the population that historically we have been interested in are those with 70% stenosis or above. And look at this pie chart. It only consists of about 18% of the population. So we're now ignoring the other 43% with less than 25% stenosis, 43%, which actually are very important in the prevention world. In fact, in a recent meta-analysis, CADRADS1 category has a hazards ratio of future major adverse cardiovascular events of between 2.4 and 13.4. So again, if we exclude CADRADS category 1, we will miss out on helping a big segment of the population at risk for major adverse cardiovascular events. And next slide. And so again, thank you very much for this opportunity to present today on this very important topic. And hopefully this will be available for our patient population very soon. Thank you.
Thank you so very much, Dr. Martin, for your great presentation. I'd like to then now move on to our third presenter. Our third presenter is Dr., please forgive me if I do not pronounce your name correctly, Dr. Chinayan, who is representing the Society of Cardiovascular Computed Tomography.
Thank you so much. Can you hear me well?
Yes, we can.
Okay, great. Thank you. Thank you, Dr. Nachatsky, for inviting me and allowing me to speak today. I'm Dr. Kavita Chinayan, and I'm representing the Society of Cardiovascular Computed Tomography today. But I'm also a clinical cardiologist at Corewell Health in Royal Oak, Michigan. And I have worked extensively in the area of cardiac CT for nearly 2 decades. and I understand its use and applications quite well in prevention, treatment, and rehabilitation of coronary artery disease. So I really appreciate the opportunity to speak with you. By way of background, SECT represents over 3,000 cardiologists and radiologists who perform cardiac CT in the US. And on behalf of the society, we support the CGS's draft LCD on AI-QCT and really commend the MAC for its coverage policies regarding this very important tool. And our goal today is, as with Dr. Min and Dr. Martin, to recommend the addition of language within 2 of the clinical indicators specified in this draft policy and provide a brief clinical justification for each of these suggestions. Because these 2 speakers have brilliantly spoken about the issue, I think I'm going to be able to cut it short. We will also submit comments and accompanying material before the deadline. Thank you. Next slide, please. So as we have seen in the previous 2 talks, we have come a long way from the time that we really emphasized the degree of stenosis as the main important event in the diagnosis of coronary artery disease. Over the last decade or so, plaque identification and atherosclerotic burden has really superseded the emphasis on stenosis detection alone. We know from several studies that plaque provides prognostic value in predicting adverse cardiac events, and numerous studies now, as shown in these particular ones here from Advance and from other studies, show a significant survival, mortality and morbidity benefit with understanding plaque distribution and atherosclerotic burden. Next slide, please. So at the moment, just for anyone who doesn't know how this AI-QCT is performed, we have patients with suspected coronary artery disease who undergo a coronary CTA. The CT is read by an interpreting physician, and then there is either classification of no plaque, which actually happens in about 40% of patients undergoing coronary CTA that have absolutely no coronary artery disease and no plaque, but 60% of patients end up having some degree of plaque observed on the coronary CTA. And this can vary between various levels of coronary stenosis from anywhere from less than 25 to more than 90% stenosis. And then we can talk about hemodynamic assessment thereafter. Next slide, please. So in terms of clinical interpretation, AI QCT, real world clinical data, and our decisions as cardiologists actually all tie together. So on the left, you see AI CPA, which provides insights with quantified plaque volume by plaque type. And then we look at the nomogram data, which provides a population context of where a patient's plaque burden stands. And then we assess risk based on outcome studies like SCOT-HEART, which has been referenced by both the previous speakers. And this demonstrates that the higher the plaque volume, the greater the patient risk. And then we go on to possible therapies based on CADRATS, which is an updated interpretation and understanding system of coronary artery disease based on plaque as well as stenosis. Next slide, please. So at this time, we too are requesting 2 updates. The first one is to add stable symptomatic patients. So the draft coverage indications read, the patient presents with acute chest pain and no coronary artery disease. And this is a really very good coverage indication. We, SECT, on behalf of SECT, we are also requesting this to be updated to read that patient presents with stable or acute chest pain and no coronary artery disease. Next slide, please. So the clinical justification for this request, again, based on the previous 2 talks, is the very good data now that we have from even the recent chest pain guidelines is that in stable chest pain, in intermediate to high risk patients, coronary CT angiography is actually very effective for diagnosis, for risk stratification, and for guiding treatment decisions. And in those patients that have non-obstructive coronary artery disease with stable chest pain, CTA is very reasonable for determining atherosclerotic plaque burden and progression. And so too with acute chest pain. Next slide, please. The second requested update is to include CADRADS-1 and CADRADS-4 patients. So the draft coverage indications currently read, the patient presents with acute chest pain and no known coronary disease and is classified as intermediate risk, CADRADS-2 and CADRADS-3 category on CTA. SECT requests this to be updated to include intermediate risk and CADRADS-1, 2, 3, or 4 category on CTA. Next slide, please. The clinical justification of this request is, again, to be in alignment with the current data, which really help us in making decisions with regard to therapeutic management and how to triage these patients to further either invasive or the other kinds of testing, as well as specific therapies that they may potentially benefit from very specifically. And so this is true for both acute chest pain as well as stable chest pain. Next slide, please. So I wanted to thank you again for allowing me to speak today and to present our viewpoint on this. And we really commend, again, we commend you for this very important step. Thank you very much.
Thank you so very much for your presentation. I'm going to proceed then now with our fourth presenter, which is Dr. Rogers. And Dr. Rogers is representing HeartFlow. Thank you.
Great. Thank you, Dr. Nachowski. Can you just confirm you can hear me okay?
And I can. Thank you.
Thank you. So first, by way of disclosure, I am a full-time employee of HeartFlow, and that's my declaration of potential conflict. I'm also a cardiologist. I'm an interventional cardiologist and a practicing cardiologist for many years at the Brigham in Boston. I would start with commending, just as Dr. Chennaiyan said, WPS for the thoughtfulness that has gone into this and the, I would say, forward thinking, recognizing what the other speakers have said of how critical these tools are and this step is for really changing the playing field in the management of coronary disease. If we go forward to the next slide, please. What I would like to do is give a very brief overview of what this quantitative plaque analysis is, what it does, what some of the clinical evidence is, just very briefly, and then really spend the bulk of the time on a couple of suggested edits to what is at its root really an excellent draft LCD. So I'll go to the next slide, please. Just to background, you've heard lots of background from the other speakers. I would highlight a couple of things on the right of this slide, and this is really going to be germane to the discussion about very specifically the CADRADS-4 population, as Dr. Chennaiyan just recommended being added, and I think what you're going to see we would make the same recommendation. And that is the following, that if you look in the middle and the bottom on the right, that even in patients where they are at high risk and coronary disease is known and they're on medicines. So for example, the argument is made around CADRADS-4, look, these people have severe disease, they're all supposed to be on medicines. The fact of the matter is they're not. 2/3 of patients on lipid-lowering agents do not achieve their targets. A recent study in a very highly managed study of new pharmacologic agents to lower cholesterol, sort of hyper-caring the patients, 30% of patients were not at goal. So I think any tool we have that can be used to help convince patients of the value of taking their medicines, we really should leverage, and that's going to come to play in the CADRADS-4 discussion. So if you go to the next slide, please. Just by way of very brief background, what has been pointed out before is that there is, I think, an incredible consensus among the different specialty societies and among practitioners, summarized here from the CADRADS document itself, that demonstrating the overall amount of coronary plaque by CTA has a strong association with incident coronary heart disease events and may offer stronger prognostic value than merely the presence or absence of stenosis or clinical risk factors, et cetera. You go to the next slide, please. One of the examples, this is HeartFlow's approach, just so people have a sense of what exactly these products look like. This is one, so we are able to measure the exact cubic millimeters of plaque which exist in the coronary arteries. It's not a derivative, it's not calculated, it is an actual measure of the plaque burden of coronary plaque in the coronaries. And then if you look on the right, we have the included piece of, for patients, once one knows their sex and age, to say, you know, amongst your age and sex matched peers, this amount of plaque is at the 50th percentile or the 20th or the 95th or what have you. Again, an important tool in dialogue with patients. Go to the next slide, please. There is really strong evidence in the literature of the accuracy of this quantitative AI-informed quantitative plaque assessment compared to what is widely considered the gold standard of intravascular ultrasound. I think that box has been checked. And if we go to the next slide, please. Finally, in the evidence, there is growing a body of evidence that demonstrates, and this is critically important, how this will change physician behavior. So if you sort of think under the category of clinical utility, there's data saying, look, in a half or 2/3 of patients, their management will be different once their physician sees this sort of quantitative information compared to what that management would have been with everything else the same, minus this one piece of information. You go to the next slide, please. We can skip this. Go to the next slide, please. So in terms of the proposed modifications we would suggest, again, some of these will look familiar from the prior speakers. If you go to the next slide, please. The first is to revise the coverage to include stable chest pain. You've heard this from the others. I just want to call out a couple of specifics just kind of for tracking in the document, which may be helpful. Current coverage reads, as you see here, acute chest pain. Our suggested edit, very similar to the prior speakers, is to add stable or acute chest pain to this clause. If you go to the next slide, please. The background for this has been discussed. The guidelines are very clear of the role of CTA and of plaque analysis when plaque is found across the spectrum of chest pain presentations, especially stable chest pain. The second at the bottom, and this is sort of perhaps more just in the tracking mode, the draft LCDs states that patients should be eligible for CTA and that CTA should be performed in patients with stable coronary symptoms. So not having stable in this document, it makes it kind of internally inconsistent, if you will. The second is there is an LCD, as you know, in place. Go back, please. There's an LCD in place for FFRCT, which is considered medically necessary for both acute and stable chest pain patients. So again, for consistency across this sort of landscape of CTA, we think it makes sense to make sure everything is aligned. If you go to the next slide, please. The second of our two suggestions, if we go forward a slide, thank you, is this notion the others have spoken about broadening the CAD-RADS categories for which these tools will be indicated. You see the text, the verbiage at the top as it is. Our recommendation is to add both CAD-RADS 1 and CAD-RADS 4. That would become, again, a clerical note at the bottom. That would also require updating a secondary clause in the limitations section to read 99% and to eliminate the exclusion of CAD-RADS 4, just for tracking. And then my final slide, the next slide, is the rationale for this. And this is, I think, really important. This gets back to that very first slide about how often people, despite having known risk and coronary disease, are not adequately medicated. Is in the DECODE study, which is published as a utility study looking at decision-making. The observations are as follows, that amongst patients who are in CAD-RADS 1, so a little bit of plaque, not a lot of stenosis, some plaque, not a lot of stenosis. When we provided this quantitative information to clinicians and said, here's a CAD-RADS1 patient. You're managing them as follows. You've seen their CT. Now here's the quantitative plaque information. Are you going to manage them differently? 40% of patients had different management in CAD-RADS1. 40% had different management. And almost always it was an intensification of therapy because of the realization of, oh my goodness, that's really a lot of quantified plaque, especially non-calcified plaque. Second point on the bottom, for CAD-RADS 4.
2 minutes remaining.
Thank you. For CAD-RADS 4, where it was mentioned earlier, those patients really, one would think would be managed pretty intensively. First of all, the guidelines, the CAD-RADS document itself clearly suggests, as Dr. Min showed, that these patients should be have plaque assessed. And the second, in the same study of utility, we showed CAD-RADS 4 patients to clinicians and said, how will this plaque information change management? And although the theory might be it didn't change at all, the fact of the matter is it led to an intensification of therapy in 94% of patients. So if you think about it, excluding CAD-RADS 1 or CAD-RADS 4 or both is going to deprive those sets of patients from this quantitative information and from the medical management intensification, which is ensuing, and we see happening in these published clinical studies. So thank you very much for the opportunity to present. Needless to say, we will be providing all of this in the written comment period, just as you instructed, Dr. Nachotsky. And again, thank you.
Thank you so very much, Dr. Rogers, for your presentation. Our last presentation for this draft LCD is Dr. Kachi, who's representing Washington University.
Afternoon. Can you guys hear me okay?
Yes, we can. Thank you.
Thanks for having me. I really appreciate the time and the opportunity to share some of my experiences with this line of work. So I'm a cardiologist here at Barnes Hospital, Washington University. I have an appointment in the Mallinckrodt Institute of Radiology, where I read CT and MR and other imaging modalities as well in the cardiac space. Next slide, please. I have no relevant disclosures. So there's a lot of redundancy here. I think we've heard a lot about the importance of this topic. Just very quickly, this is straight from the CDC website. Heart disease is the leading for men, women, and most racial groups. One person dies every 33 seconds. 1 in 20 adults above the age of 20 have coronary disease, and about 1 million people a year have a heart attack. So it's very prevalent, very costly, very big a contributor to morbidity and mortality in our population in the country. Next slide, please. I wanted to take the opportunity to add a different flavor to this presentation today and to add some clinical context to what we do on a day-to-day basis when we take care of patients. As I see patients in the outpatient and inpatient setting, all I'm thinking about is where are they on this coronary artery disease timeline? Are they in the left-hand side where they have no atherosclerosis, or are they in the right-hand side where they've had an event and we're trying to prevent another event? This is the classic paradigm for thinking about patients and thinking about prevention, primary prevention being before a heart attack or an ASCVD event, and secondary being after that. And I think what we've shown already with the prior presenters, and what I'll try to emphasize, is that maybe we should shift that timeline leftward and try to prevent rather than the actual heart attack event. Next slide, please. So how do we think about patients that present to our clinic? We look at them, we see what their risk factors are. Are they smokers? Are they diabetics? Do they drink a lot of alcohol? Are they obese? Are they under enormous amounts of stress? And then we add on other clinical parameters. If you play the next slide. Maybe we listen to their heart exam. We look at their biomarkers, their blood biomarkers. We look at their EKG. Next slide, please. And then we think about them as either having low, intermediate, or high risk. Next slide, please. And if they're low or intermediate, we think about non-invasive testing. If they're high risk, maybe we go straight to the cath lab. Next slide, please. And traditionally, how we categorize them, in addition to what I've just said, is we think about these classic risk stratifying tools like the Diamond Forrester classification. And this very simply says, how is their chest symptom? Are they a man or are they a woman? Do they have risk factors? Where are they in their age group classification? And then we kind of think about, are they high, intermediate, or low risk? And based on this, we know that we can vastly overestimate the degree of the presence of coronary disease just by going by risk factors alone and by risk classifying tools. Next slide, please. More contemporarily, we look at something like the ASCVD pooled cohort equation, which takes in similar variables and spits out a number in terms of the percent risk of a patient having a stroke or heart attack in the next 10 years. In this particular example, I have a 59-year-old male with those blood pressure and cholesterol parameters. And this particular calculator says that it has a 9.5% risk of having an event in the next 10 years. And that's traditionally considered intermediate risk. However, based on the cohorts that were included in this equation, it can underestimate significant populations in our U.S. population, including American Indians, South Asians, Puerto Ricans, and it can overestimate East Asians, Mexican Americans, and obese patients. So it's not a one-size-fits-all. It's not perfectly accurate, and it leaves a lot of room for improvement. Next slide, please. And so what do we do when we see patients? We think about stress testing with either exercise or pharmacologic testing. So next slide, please. We can put them on a treadmill. If you hit, and see what happens to their symptoms. Are they reproducible with exercise? Does their EKG change? Next slide, please. You can put them on a treadmill with an echo before and after to see if there's differences in wall motion, and you can identify coronary disease that way. Next slide, please. You can do nuclear testing to see if the perfusion changes before and after a provocation of stress. Next slide, please. Or you can do cardiac MRI and see what happens before and after a stress agent. All these modalities, I think, are effective, and it's what we use on a clinical basis. But next slide, please. What you'll see is that, next slide again. If it's a positive study, one more time, please. You'll identify disease in the later stages of atherosclerosis. But if it's negative, you'll miss the opportunity to intervene and to act on patients who don't have significant severe plaque that's causing ischemia. And that's where I think coronary CT and all the tools that we've talked about today come into play. Next slide, please. A coronary CT can give you direct anatomic mapping of what's going on in the arteries throughout the entire path of that atherosclerotic cascade that I've shown you before. Next slide, please. And with this tool, you can create a map of each artery and tell the patient and the providers that are ordering it, where are they on this map? In the top right of this slide, I have it broken down into the different CAD-RADS categories, from no CAD to minimal, mild, moderate, and severe stenosis. And we can do this with a fair amount of confidence. Next slide, please. Next slide again, please. And this illustrates that we can identify patients with this modality throughout the natural history of atherosclerosis, not just at the end of it. Next slide, please. And why is this important? Well, as we've heard about in previous presentations today, the extent of coronary disease correlates with mortality. The more coronary disease you have, the more you're likely to have a mortality event. And this is pooled cohorts of many different prospective trials looking at medical therapy arms in patients who did not get intervention, stratified by the amount of disease that they had. You can see as they go from 1 vessel to 2 vessel to 3 vessel disease, mortality increases. Next slide, please. And what's been emphasized before is that the story doesn't end there. It's not just how much disease you have. It turns out that patients that come in with an acute heart attack, next slide, over 70% of them actually have precursor lesions where they had a heart attack that were not 50% stenotic. Over 70% have less than 50% stenosis at the site where they had an acute plaque rupture event, where they had an acute ST elevation MI. Next slide, please. And next slide again, please. The same is true for patients who present with sudden cardiac death, or if they come in with a cardiac arrest where they had to get resuscitation outside the hospital and were brought to the hospital. If you look at autopsy specimens, the culprit lesion for the event of sudden cardiac death, if it's analyzed at autopsy, is estimated to be less than 70% stenotic in over 70% of patients with out-of-hospital cardiac arrests. So this is true both for the severe events of heart attacks and for sudden cardiac arrests. These non-obstructive lesions are very clinically important to us. Next slide, please. So, next slide again, please. I would propose that we would change the timeline to looking at primary prevention before plaque ever develops, and secondary prevention at preventing the progression of adverse. Next slide, please. And some of these high-risk features that we look at on CT to identify plaque as it's evolving are listed here. Positive remodeling, spotty calcification, low attenuation plaque, napkin ring sign. These are things that we look for all the time on CTs, especially in patients that have non-obstructive plaque, to identify risk. Next slide, please. We do this because there's plenty of data that you've already seen today. In addition to that, I wanted to show you the RomaCat2 study looking at patients presenting to the ER with chest pain. And if they have these features, you can be 5 to 10 times more likely to have a true heart attack event if you have these adverse plaque features. So adverse plaque features, even in the absence of significant stenosis, are very prognostically meaningful, as you've already heard from the other presenters today. Next slide, please. In addition to that, and not only identifying plaque that is adverse, you can also track plaque evolution over time. So if you take patients and you
2 minutes remaining
baseline to follow-up, you can see that the plaques can remodel in a positive way and become less adverse. And patients who have never taken statins, you can see how their plaques can evolve over time. And analyzing plaque characteristics for patients that have stable symptoms, non-obstructive disease, is thus very important. Next slide, please. And so tying this back to the purpose of this meeting today, using tools that help us become more efficient, more accurate, and more consistent across patients, both longitudinally and across different patient populations, is very important to us clinically. We want to be able to provide this very valuable prognostic information in an accurate way, in an efficient way that's able to meet the demands of our patients in need through our imaging labs. Next slide, please. This is a slide you've already seen earlier today, so I won't belabor it too much, but we can quantify the plaque data. We can populations in the right context, assess their risk in a precision model rather than a calculated model based on cohort equations, and then we can offer possible therapies for them. Next slide, please. And so I wanted to end with a case example of a patient that represents many of the patients I see on a regular basis. It's a 49-year-old woman with hypertension who had left-sided chest pain that improved with nitroglycerin. Her LDL, which was her bad cholesterol, wasn't that bad. It was at 70. Her pooled cohort equation gave her a calculated risk that was low, of less than 5%. No statin recommended based on that. Her nuclear stress test was normal. But I decided to pursue a CT to kind of get more information about what's going on in her arteries. So next slide, please. And what you can see here, the three main arterial systems, at first glance look like they're fine. And actually the calcium score is 0. And so at first glance, it may seem that it's okay. But on closer inspection, next slide, please.
I apologize. Time is up.
Time is up? Okay. Well, I guess
Yes.
I'll just end by saying this is an example where we can look at plaque and personalize therapies and offer recommendations where traditional testing may not have suggested that.
Thank you. Thank you so very much, and thank you for understanding our time constraints. With the few minutes that we have remaining here, I am going to go to, as far as open comments, if there are any open comments, please, if they're supporting what the presenters have said, I would ask that you just give us your written comments unless you have something else so that we can proceed to the other draft proposed LCDs.
So raised hand if you have anything to say other than what has previously been presented. And I see no raise hand icons at this time.
All right, thank you so very much, Rich. So let us proceed to the next proposed draft in numerical order. That is DL 39905, cataract surgery. This is a new LCD. It's just by WPS, so it's non-collaborative. It was MAC initiated. There is no prior evidentiary meeting. Our WPS lead CMD is Dr. Claudia Campos.
Good afternoon, everyone. This LCD outlines limited coverage cataract surgery procedures as described in the coverage indications of the policy. WPS coverage indications for cataract surgery are divided in 3 major categories. When visual function no longer satisfies patients' needs despite corrective lenses, when cataracts impede the visualization of the posterior segment of the eye during diagnosis or treatment, and as prevention in cases of cataracts causing or coexisting with other intraocular pathologies resulting from cataracts. A comprehensive medical evaluation, patient's consent, and anticipated refractive outcomes must be clearly documented in the medical record. As far as the covered limitations, surgery is generally not performed in both eyes at the same time, and complex extracapsular cataract extraction involves any extraordinary techniques and is not related to the surgeon's perception of the surgical difficulty. WPS's LCD is aligned with current best practices recommended by society guidelines based on systematic reviews such as the 2021 American Academy of Ophthalmology Cataract in the Adult Eye Preferred Practice Pattern. We will now take oral comments about this new LCD.
Thank you so very much, Dr. Campos. So now we are open it for any open comments. I appreciate your detail, yet how concise you were in regards to this LCD proposal.
There are no raised hands at this moment, so we can move on to the next.
Thank you. Thank you so very much. The next proposed draft is DL 39911, total joint arthroplasty. This is a new LCD. It is MAC initiated by WPS. It is a solo LCD, no prior evidentiary meeting. Our WPS lead CMD is Dr. Joelle Vlahakis.
So this LCD outlines limited coverage under coverage indications, limitations, and or medical necessity for total joint that includes knee and hip or hip arthroplasty and revisions. So the reasons for requiring hip or knee joint replacements vary, but are typically related to the degeneration due to osteoarthritis, rheumatoid arthritis, or trauma. Guidelines for performing these procedures have been published by the American Academy of Orthopedic Surgeons, the American College of Rheumatology, and the American Association of Hip and Knee Surgeons, and other reliable sources. These guidelines and recommendations have been critiqued, considered, and consolidated in this local coverage determination. So total knee arthroplasty will be considered medically necessary when one or more of the following criteria are met: failure of previous osteotomy, or distal femur fracture, or proximal tibia fracture, or malignancy of the distal femur, proximal tibia, knee joint, or adjacent soft tissues, or failure of previous osteotomy, or a vascular necrosis of the knee, or advanced joint disease demonstrated by all of the following: radiographic supported evidence, and there's a few things listed in the LCD: pain or functional disability attributable to the advanced joint disease, and history of failed conservative therapy, which is clinically appropriate for the patient's current episode of care and shall follow patient's preferences. It must include either unsupervised exercise or completion of a supervised physical therapy program, and one or more of the following: topical or oral anti-inflammatory medications, analgesics, assistive device use, weight reduction as appropriate, acupuncture or therapeutic intra-articular knee injections as appropriate. There's also a provision for replacement or revision of the total knee replacement, which include disabling pain or functional disability, progressive or substantial periprosthetic bone loss, or fracture or mechanical failure of one or more of the components of the knee joint, infection, aseptic loosening of one or more components, failure and wear of the prosthetic components leading to symptomatic synovitis, or implant or knee misalignment, or extensor mechanism instability, or knee stiffness and arthrofibrosis. Now we move on to total hip replacement. This will be considered medically necessary when one or more of the following criteria are met: malignancy of the joint involving the bones or soft tissues of the pelvis or proximal femur, avascular necrosis, that's osteonecrosis of the femoral head, or fracture of the femoral neck, or acetabular fracture or non-union of or failure of previous hip fracture surgery, or malunion of the acetabular or proximal femur fracture, or advanced joint disease as evidenced by all of the following: radiographic or MRI supporting the advanced joint disease, and pain or functional disability attributable to the advanced joint disease, and history of failed conservative therapy, clinically appropriate for the patient's current episode of care, and shall follow patient's preferences. It mirrors very much the joint replacement suggestions for the knee replacement. There's also provision for replacement or revision of the total hip joint, including instability of one or more or both components, fracture or mechanical failure of the implant, recurrent or irreducible dislocation or infection, or clinically significant line length inequality non-amenable to conservative management, or treatment of a displaced periprosthetic fracture or progressive or substantial bone loss, or clinically significant audible noise or adverse local tissue reaction. Thank you for sitting through that.
Oh, no, thank you so very much, Dr. Vlahakis, for your detail and a thorough summary. At this point, we will accept comments, any oral comments regarding to this new draft.
Click the raised hand icon or *3 on your cell phone. There are no comments at this time.
Thank you so very much. And our very last one is DL39051, cosmetic and reconstructive surgery. This is an existing LCD. It is a WPS MAC initiated. It is primarily just a revision update. There is no evidentiary hearing. Our lead CMD is Dr. Joelle Vlahakis, who will provide a brief summary.
Brief being the operative word. I appreciate everyone's attention. So this is a previous LCD, as mentioned, includes clarification of coverage and requires a change in the wording substantial enough to submit it for open comment. This is just an updated portion which includes the section specific to abdominal lipectomy and paniculectomy only. The most important clarification is that paniculectomy will be considered medically necessary when the pannus or paniculus hangs below the level of the pubis and one or more of the following conditions are present, including chronic intertrigo, difficulty walking or functional impairment of activities and activities of daily living due to pannus size, chronic pain, or ulceration created by the abdominal skin fold. There's also a provision that if the procedure is being performed following significant weight loss, in addition to meeting the criteria noted, there should be evidence that the patient has maintained a stable weight for at least 6 months. And for patients whose weight loss is the result of bariatric surgery or the like, that the paniculectomy should not be performed until at least 18 months after bariatric surgery and only when weight has been stable for the most recent 6 months. And I'll end there.
So much again, Dr. Vlahakis. At this time, we will now take any oral comments regarding this revision update of this draft LCD.
Okay, I see there are no raised hands at this
Okay.
time.
Thank you so very much. So what I'd like to do is to say that I believe that this was an excellent open meeting. I would like to thank all the presenters, all the attendees, anyone who gave comments in regards to this. It is through your interaction that we are trying to do the best for our beneficiary. Please remember, if there are any on the line here who would like to provide written comments, again, one more last time, please feel free to send the written comments in. Please note that there are 2 open periods that close on July 14th for the first 5 LCDs and July 20th for this last one, which is cosmetic and reconstructive surgery. Send them to the Medicare policy comments at WPSIC.com. Again, please make sure that that on the email you include the topic of the LCD, provide any other published scientific studies and or literature to support your message. Prior to adjourning, again, thank you everyone for attending this. I'd like to thank my fellow colleagues, CMDs, for your informative summary of these draft LCDs and all your time and efforts in the writing of these proposed LCDs. Thank you all for your comments for this, and at this time I will say that the meeting is adjourned.